Good afternoon. Actually, rather than talking on conservative, I would be just presenting as a cascade of cases so that you can have some take-home message at the end of the talk. So as we know, rising age means more degenerative diseases. And as everybody knows, the average lifespan is increasing in all the countries over the world, whether it is developing countries or developed country. So this is going to be a future for the coming generations of spine surgeons. They will have to treat so many spinal fractures. Because if you talk of hip and knee, there are only 2 hips and 2 knees, but there are so many vertebral bodies which are likely to get fractured. And this is from a famous paper of Professor Lieberman, who had demonstrated that this is an X-ray taken on 31st August 2000, showing 16-degree kyphosis. And just by giving bed rest, another X-ray taken, which shows that the kyphosis is increased. So what notion we have, it just make the patient do bed rest and everything will be all right, doesn't come true in each and every case. So you have to be alert, you have to have good follow-up to decide whether your patients will be better with conservative treatment or they require some augmentation or surgical procedure. And when you talk of surgical procedure, whether it is anterior, posterior, or minimally invasive, is again a dilemma in most of the surgeons' mind. So let us consider what are the objectives when we are talking of osteoporotic fractures. These are essentially low velocity fractures. We don't consider road traffic accidents in this. So purely osteoporosis, low velocity, and the objective is early diagnosis, restoration of anatomy as possible. And we have to consider a geriatric group of patients which come in the zone of osteoporosis or osteopenia. So early intervention may reduce, these are the following advantages what we have, might reduce the duration of pain, further collapse of vertebral body, deformity, kyphosis, and then restricted chest capacity leading to embolism, pneumonia, and further complications. So let us consider case by case, few examples. So this is 74 years, diabetic female hypertensive. She had angina, also has urinary infection. And she has already been tried on 3 months of bed rest. And when she came to us, this was a picture in April 2003. Actually, Pune-Bombay is a famous road, and she was traveling from Pune to Bombay in Asiad bus. And this was her subsequent pictures. You can see gradual collapse occurring. And when she came to us, this is July 2003 picture. That time she has come to us in August, and she developed what is called as classical Kummel sign or avascular necrosis of vertebral body. So this is September 2003, pre-vertebroplasty. We treated her with just vertebroplasty. And then this patient disappeared to come for follow-up directly in February 2000 with a lot of packets for me. And she had completed a Char Dham Yatra during this period of 4 to 5 months. And this was her picture, no fresh collapse, no adjacent level fracture, and she had completed Char Dham Yatra. So this is February 2004, and this is 5 years follow-up. You can see there is no collapse, no adjacent fracture. So this is the ideal indication for bone augmentation by vertebroplasty. Next is 82 years old lady who had multiple fractures, bedridden, nobody to look after her because all her sons and daughters are in US. So this is where we can take help of this augmentation procedure done simultaneously in single sitting, and she is doing fine. So when we talk of augmentation of procedure in particularly osteoporotic fractures, we have 2 principles, whether we want to restore the vertebral body height, where we don't want to restore, we just inject the cement, and that is termed as vertebroplasty. It is just a stabilizing procedure where no correction of deformity is aimed at. If you want to restore the vertebral body height, this can be done by various modalities, whether you do mechanical pressure to create a void by various material which are available, like Optimesh, Aculoplasty, Vex 300, Sky Expander, or you use hydrostatic pressure like in kyphoplasty. And when you don't want to create a void, just use hydrostatic pressure. This is another modality called as vesselplasty. So these are all for MISS low energy non-fusion techniques, where we are not talking of vertebral body fusion. So this is an example, 6 weeks old osteoporotic fracture, L1 treated with bed rest and conservative treatment. You see the collapse, 0.92 is the anterior height, treated under local anesthesia, nice correction, and this is 6 weeks follow-up. Now she is walking. She has already traveled to US twice in the last 4 years, before and after the pandemic. So this is our latest situation, treated purely under local anesthesia, and same day or next day patient can go home. This is another old family physician practitioner who had fall, 82 years, treated with conservative management, developed avascular necrosis, and this was a situation when he visited me. Again, it was treated by vesselplasty. You can see the implant insertion under C-arm control, vessel inflating. This is a final picture, and this is 6 months follow-up X-ray. There is no collapse, no adjacent level fracture. That is the beauty of this, and patient do walk on the same evening or next morning. This is another 70 years female who had recently undergone angioplasty. She was on double anticoagulants and was diabetic, fall, and after that, after being treated conservatively, she became paraplegic, now could not get up. And these were her pictures when she visited us. So again, the issue was to grow anteroposterior surgery. We chose surgery under local. These are the C-arm pictures. You can see vessel in the position, and this is 1 year follow-up. Everything was done under local anesthesia. So this is the beauty of augmentation and local anesthesia to prevent the risks of general anesthesia and major morbid surgeries. This is a very obese patient of mine. Initially, she had fracture L2 because of fall from stair in September 2013, where we treated her by vertebroplasty, and she was put on teriparatide as anti-osteoporotic treatment. And this was her picture in 2005, 2 years follow-up now. And at this point, she again had a fall in 2019, and she had a fracture at L1. But this time you can see the posterior burst, and hence choosing just vertebroplasty was not enough. So we had two options, whether to do MISS fixation or try something new. So vesselplasty was done under local anesthesia. You can see implant inside, it is getting inflated, vesselplasty done, and my needle is removed. That is the final extreme right, and you can see the previous vertebroplasty. And then she had already completed teriparatide course, hence she was on denosumab. So this is a picture after first dose of denosumab, first follow-up. And this is a next follow-up, second injection of denosumab, September 2019. You can see nice osseointegration of the HA cement, HA with polymethyl methacrylate cement. You can see nice interdigitation of the cement with bone marrow. So that is the beauty of this. This is 115 kg old lady. Both the surgeries under local anesthesia, no collapse, she is walking on her own. And both the times she was discharged on the very next day because she comes from periphery of Pune district. This is another interesting case, 84 years gentleman. He had fall 6 months ago, September 14, treated with conservative management. Next, he had another fall household, L2 fractured in December, and since then he was bedridden for last 6 months, developed UTI and all problems related to the bedriddenness. And this point he visited us. This was a fresh MRI done in December that time. You can see fracture D10, D12 and L2. These are the 3 fractures, and apparently on MRI and also clinically they were all tender. So each required something to be done for it. So doing long level of fixation was out of question considering his age and physical condition. So these are the axial view where you can see D10 also has posterior burst. So standard vertebroplasty or kyphoplasty could not be done. So under local anesthesia, what we have done is different modalities for these different fractures. D12, because it was 6 months old, remained collapsed, so vertebroplasty was just sufficient. For L2, we did it opened minimally, so we tried kyphoplasty using kyphon balloon. And D10 was a fresh fracture with a posterior burst. So both these modalities could not be worked, and hence we tried vesselplasty. So in single patient, you can have 3 modalities, each having its own positive and negative points. And you can see this vessel and D10, D12, and L2, all the 3 fractures treated locally with under local anesthesia, no major incision. This is 6 months follow-up. There is no further collapse. Patient is doing fine. And this was immediately second day of the surgery. Patient was made stand up. And you can see this 2 years post-op. Video is not running. Okay. And now he had undergone last year bilateral total knee also. So this is the situation what you can do for these our geriatric patients. Okay, next. So whenever you have, now the question of whether you have neurology or you don't have neurology. All these cases didn't have neurology, so I could get away with just cement augmentations of various procedures. But when you have neurological deficit, then you have to consider whether stabilization is going to improve the patient or you require decompression also. So this is one of the patients, fracture, 2-level fracture, but one had compression, so we had to, the postural correction, indirect reduction, and then fixation. And this is a 2 years follow-up X-ray. She is walking well. This another case where you can consider combination. This was a paraparetic patient because of compression fracture. So we have used cement augmented screws along with vertebroplasty on one side. So this is the situation and where you can use or consider combination of modalities. This is another army person who was treated at army hospital conservatively, 87 years old major who had already had fought in our Pakistan war and previous wars, China war. So now he is retired at home, had multiple vertebral fractures. Every time he was treated conservatively. But with this L3 fracture, which was a burst, he developed paraparesis, still treated conservatively, and he visited after 3 months. This was his situation. You can see the MRI, CT, and active fracture appears to be at L3. So here we have tried both the things combination together. So percutaneous fixations, considering his age, did vertebroplasty, this vesselplasty for burst fracture, and then stabilized. And you can see post-op X-ray, follow-up X-ray, he is already walking from second day because he started getting improving power, grade 3+, with immediately post-ops. And next day we could make him stand. So this is his post-op X-rays, follow-up. He is already walking up to 1 kilometer now. This is 4 months old situation today. So that is how you can use augmentation with fixation for various vertebral fracture. Only dilemma or the fracture which is very difficult to treat is this type of fracture where you have bursting of the body right from anterior to posterior side. And there you definitely have to use our routine modalities of fixations. But other can be dealt with various combination of procedures as per the fracture pathology. So this is the latest classification of osteoporotic fractures. So to conclude, take-home message is vertebral fractures, you should always look for progressive collapse and deformity. Implant loosening is the commonest problem which can lead to failure of surgery. So one has to be very alert of it. Newer technologies will prevail and we will have better technologies in future. So we have to keep on updating because osteoporosis is going to go with all of us till we die. No replacement for medical treatment. Whatever surgery you do, you have to treat osteoporotic with medicines. Cement augmentation, when done judiciously, can stabilize anterior column, and need for anterior surgery can be reduced, particularly in geriatric patients, which are high-risk age group. Hence, to conclude, when we do augmentation, our indications are, we do augmentation when disability is due to pains, no instability and no neurodeficit. When disability due to pains with instability, but there is no neurological deficit, we do augmentation with percutaneous fixation. When there is neurological deficit in addition to the disability and instability, then we consider augmentation, decompression, minimal decompression and fixation. So all the 3 modalities are to be considered. So as per the patient's situation, when you come into the picture, this is our protocol, what we are following. So thank you very much for patient listening. These are the books already published in various languages over the globe. Chinese and Spanish, English, any languages, it is available. Thank you for your attention.